Okay. Welcome back from lunch, everyone. I'm Randy Bateman, the chair of the subcommittee for research as part of NAPA. And we're going to get started by providing two things. One is an update on important scientific advancements over the past year. And then I'll be presenting the committee's recommendations. Dr. Jorge Yibre is going to present scientific advancements over this past year that has had an impact. Dr. Yibre is a neurologist who leads several important research studies, including the Dominantly Inherited Alzheimer's Network, LATAM, and the Latin American centers, and had started those up. He also has led research into ARIA, CAA, clinical onset, progression, genetic admixture, and many other areas. Dr. Yibre is talented in scientific research, but also in clinical and translational research. And so, Jorge, come on up and we'll present.
All right. Great. So we have slides up, and I have to say I'm really honored to be here today and share with you some of the recent findings. And I have a hard job, right? I have to summarize in 30 minutes things that happened over a week and a half at AIC and all the things that have been happening in the past years. But I would like to cover that and kind of share with you what I think will be most relevant in terms of clinical practice and implementation in the next 5 years. These are my disclosures. Right. And you all know this information, so I'll skip this brief. But something that I'm particularly kind of proud to say is that it's true we don't have a cure, but we now have disease-modifying therapies. And that's kind of a great achievement in the field. I've only been able to say that in the last 2 years. Good. And again, a lot of the things that I'm going to be presenting today really comes from years of research. We have known about Alzheimer's disease since centuries ago. And even when we today have disease-modifying therapies, a lot of this comes from some of the findings that preceded this, some of the research funding that supported research and the scientific understanding of the disease mechanism. Now, what I'm going to do today, just to try to cover these findings of what I think will be relevant in the next year, in terms of clinical implementation, I will focus in 4 elements. One will be what we have learned in the past year in terms of population-based study, how dementia prevalence is changing, what we know, what we have learned, what is the effect of the exposome, right? Different vascular risk factors in dementia rates, and at the same time, what we could learn from cross-population comparisons, what happened when we compare populations in US with other global cohorts. At the same time, I will briefly share some updates in terms of genetics, where we are going. I also want to spend time discussing blood biomarkers and how it's probably going to change how we do clinical trials, but it also have an important effect in clinical practice. And finally, I will try to summarize how all these findings are actually helping us to think in novel targets and how we implement treatment for Alzheimer's disease and related dementias. Now, I'm not going to spend a lot of time on this slide. This was recently reviewed and presented by the Lancet Commission less than 1 week ago. I know Dr. Heather Snyder will touch on these topics. But one thing that I would like to share with you is that we now know that a significant number of cases with dementia could be prevented if we prevent the main risk factors, with a special focus on when we focus, right? We see the main advantages to focus in midlife. With that said, we have seen from different population-based study that prevalence and incidence rates of dementia are now becoming more stable or have decreased in some studies. And we have data coming from US, UK, Netherlands. But this change in trends is not uniform across all population or ethnic groups. We believe that some of the stable or decrease in dementia incidence is mainly common for changes in lifestyles in high-income populations. But that's not necessarily true, the trend that we are seeing in Mexican Americans or other Hispanics group. And we also have data in the lower panel coming from international countries like Dominican Republic, Mexico. And that's also the trends we are seeing in terms of Hispanics in US, where that's a group that we expect the largest increase in dementia. Another element going beyond prevalence, over the last 10 years, maybe 2 decades, we have seen a significant improvement in what we know in terms of genetic of Alzheimer's disease. And those goes from the discovery of pathogenic mutations like those in PSEN1, PSEN2, or APP genes, but also to the development of polygenic risk score based on other novel risk factors in terms of genetic. Now, some updates from the ADSP group working in genetics, they have shown that only 3% of what we know in terms of genetic of Alzheimer's disease come from non-Hispanics. So the overwhelming majority, right, of the disease or the genetics that we know come from European descent population with lower representation. Now, during AIC, the ADSP group presented findings on how they are changing this and how they are growing a global cohort and a global representation. So we hope this will be changing in the future. And this is particularly relevant because as we start now thinking in prevention trials, using polygenic risk score that will be help us to identify who are at higher risk and enroll them in trials, but also define who will be eligible for novel therapies. Having polygenic risks that are specific to each population will be extremely relevant. Just to illustrate this, ApoE4, it's one of the higher risks in terms of genetics for developing Alzheimer's disease. Now, we know that the effect of E4 is not uniform across populations. These findings, also shared during AIC, show that the effect of E4 seems to be different across different ancestry groups. We know that E4 is overrepresented in population with higher African ancestry, like Caribbean, Hispanics, Yoruban population, but the effect of E4 is different across each of these populations. So having a better understanding on how different risk factors affect across population would be key. Another element that we learned in great details during AIC and during the last year is what is the effect of E4? And again, here I'm focused on E4, but this may be true for each of the genetic variants that have been related with ADRD over the past 10 decades. For example, if you have 2 E4 alleles and you have a Caucasian predominant descent, you have almost 15 times higher risks of developed dementia. However, this is significantly lower if you have a predominant Peruvian or European or Peruvian or Ecuadorian descent, meaning that it is a predominant Native American population, the risk goes from 5 to 10. And then if you have a predominant ancestry population like Caribbean Hispanics or European population, the risk is 2.3, 2.5, almost 3. So there is significant effect, right, of E4 across all population, but this significant effect is differential, right? So, and that's an important key to share, and this may be true for other genetics factors. Now, again, I mentioned I will be covering multiple things. Now I would like to change to blood biomarkers and how blood biomarkers may shift how we practice and how we diagnose Alzheimer's disease. This is particularly relevant because blood-based biomarkers will be more available in our populations, are easy to collect, right, and are also easier for physicians once trained to interpret these results. So I think this is the key and where we are going. Blood-based biomarkers, also we have the possibility to improve trial recruitment, and that will definitely help in designing trials that will be more cost-effective and get results faster. Now, how we will design that, and we have discussing a lot of this during AIC last week, and but of course also over the last year. How we could use blood-based biomarkers. So here we are seeing the graph that was published in Nature Medicine and thinking about suggestions, right? How this could be implemented in primary care, right? How we could use these blood-based biomarkers. One could be as part of a screening, right? And defining who are the people that will benefit the most of continue or being referred to and especially clinic, especially thinking about doing other biomarker like CSF or PET, and the ones that have a clear cut to define or make a diagnosis of Alzheimer's disease. Again, there are still studies ongoing, and this will need more validation, but this is coming to clinical practice, and we need to be prepared for that. We are already using blood biomarkers for improving recruitment in clinical trials, and as I mentioned before, this will hopefully help us to get faster recruitment, more cost-effective trials, and at the same time being able to get faster responses in how we do clinical trials. Now, early on today, this study was mentioned. I think this is reassuring on how we could implement or how we will translate from research to practice some of these blood-based biomarkers. This study actually compared the accuracy in making a diagnosis of Alzheimer's disease when physicians, both in primary care or in secondary clinic, use blood-based biomarkers. And it actually improved in a significant way, right? 90% accuracy in making a diagnosis of Alzheimer's disease. When you compare with the same physicians not using blood-based biomarkers, was 63% in primary care physicians and close to 73% in secondary clinics. So there is a significant improvement in how early we could do diagnosis. And this is particularly relevant, especially as we think in primary care, right? A significant number of cases with Alzheimer's disease or early MCI are missed in primary care. And sometimes just because the physicians don't have the time to put in cognitive assessment, but at the same time, they may need more resources to approach a diagnosis. All right. Similar to what I just discussed in terms of genetics, most of the blood-based biomarkers have been assessed, right, or what the responses we know comes from non-Hispanics white populations. However, I think there is hope in the future. Several studies are now being funded to conduct more research in diverse populations and how these studies will inform the use of biomarkers. This is particularly relevant because we also see difference in terms of vascular co-pathology in this diverse population, where frequency of vascular disease in Hispanics and African American is higher. The same for renal disease. So what is the impact of this co-pathology, vascular disease, in the performance of these blood biomarkers at primary care? So that's a key question that we need to answer. Here I'm showing a map both in US and Latin America of studies that have been funded with a specific focus of assessing blood biomarkers in diverse population, both Hispanics but also African Americans. So we'll be getting a lot of responses from these studies in the next year, and hopefully we'll have a clear way to implement worldwide in primary care. Now, changing to how all these findings in population studies, biomarkers, and genetics are helping us in clinical trials. When we think about intervention, especially in neurodegenerative disease, in Alzheimer's disease, I usually like to think on, all right, we could do prevention, right, and that's stopping the disease before the onset. We could also do stopping the disease, right, disease-modifying therapy to arrest or stop the disease progression, and we also modify the course of the treatment, right, or the course of the disease progression. And that's shown in the graph you are seeing on your left. Now, we learned during AIC that there are many targets that we are focusing in terms of treatment, many clinical trial thinking on how we address Alzheimer's disease from multiple points, how we think about prevention. The following chart I'm showing here, the outer ring shows different interventions, right, mainly lifestyle intervention modifiers, and I want to spend much time on that. I think Dr. Heather Snyder will also focus on this. But the other ring also shows the variety, right, of the different therapies that are being used. to target a disease that goes now beyond A beta targets, right now focusing on tau, inflammation, ApoE4. So there are many targets on goal. Now, for Alzheimer's disease, something that we have changed, right, and we are now thinking in many ways, and this was highly discussed during AIC and over the last year too. It's how and when we treat Alzheimer's disease. For this concept, I like to think in three main concepts. One concept of primary prevention, second, secondary prevention, and third, symptomatic treatments. Primary prevention, the goal is intervene early enough to avoid the start of the accumulation of A beta plaques in the brain, right? And for that, we'll need to go long-term prevention trials, thinking when we intervene. Secondary prevention, now we are thinking in A beta deposit, but we also want to remove tau and ideally prevent the onset of the clinical symptoms. So, and that's how we are moving now with clinical trials. And we have seen evidence that the early we intervene, the more clinical benefit. And I will be showing a few examples today too. Now, just to call out many trials going worldwide in terms of lifestyle intervention. The worldwide fingers is a great example of that, with the sister study in the US being Pointer US, and this will be discussed in the session later today. Now, again, as I mentioned before, it's a great moment to be in Alzheimer's disease. Over the last 3-4 years, we have seen approval of 3 disease-modifying therapies for Alzheimer's disease. This is a unique momentum, and we should make use of this momentum. But the other question is, now that we have these disease-modifying therapies, what is next? What is where we are going next in terms of stopping the disease? And again, these approved drugs are able to delay progression, but probably is not enough yet for families and people living with the disease. So we should continue looking for a cure on this aspect. There are many targets or many ways we could target amyloid. I will skip that. But I would like to highlight what we have learned, right, with these approvals. We now have clear evidence that significant amyloid removal leads to a cognitive benefit. Here I'm showing some of the trials that receive, or some of the drugs that receive regulatory approval, and we are seeing that those that actually were able to remove amyloid beta to almost normal levels are the ones we are seeing a significant benefit in terms of cognition. And this is really important because this is a proof of concept of the use of amyloid therapies in these populations. Again, mentioned early today, these are some of the findings. We have seen that lecanemab and donanemab show benefit not only in their primary endpoints, but also in many of their secondary endpoints, creating the hope we are waiting for the field. But again, the question we have now, where we are going next. This slide referred to another presentation during AIC and refers to what I think may be the first evidence of prevention in Alzheimer's disease. These are the results from the DIAN TU01 OLE trial, where we use gantenerumab. And what we saw here is that the people that were treated longer with gantenerumab, right, the mutation carriers that received treatment for a longer period, we actually see a significant benefit in delaying the disease onset or even the progression, right? So in the group that was treated for an average of 8 years, we actually saw a 50 chance decrease of becoming symptomatic. And this is extremely relevant because these are mutation carriers. These are people that usually start the disease around 35, 45 years, right? So having this impact is a significant proof of concept for prevention in this population that we could also expand to sporadic disease. So this is really rare, and again, there are some caveats on the trial, being open label extension, using an external placebo cohort for the assessment, but again, it's significant evidence of what we are seeing in terms of prevention in the field. All right. Now, the other element that we saw a lot discussed during AIC, it is prime time for tau therapies. We now have disease-modifying therapies that are able to remove amyloid beta, but there are now several initiatives thinking about how we also implement tau targets, how we implement combination trials. And that's why I think that in the next 5 years will be prime time for tau therapies. Similar to A-beta, there are many ways that tau could be targeted. Here I'm just showing a few of those, right? It could be even by removing tau tangles, but also using genetic therapies, using ASOs, right? So there are many ways that we could target tau. There are several phase 1b, phase 2 trials that actually show result during AIC. And again, there is a huge variability on where we are going in terms of these targets. And I think that's really encouraging on how, what is coming in terms of pipeline, in terms of tau. Now, with tau, we would like to avoid something that happened also during when we were trying A-beta therapies. And a lot of questions now is, all right, what is the right target in terms of tau, right? Where we should start with tau. Make sure that we don't use lower doses. We need to use the right amount of those. And the other element, what is the best time for intervention in terms of tau? So these 3 questions that we actually suffer when we were trying to move forward anti-amyloid therapies, we will also have the same challenge now with tau. And we need to figure out each of these questions. Now, again, prime time for tau, but it's also prime time for combination trials. Ideally, as I mentioned, a combination trial will target the 2 main pathologies that we see in Alzheimer's disease, A-beta, but also tau tangles, right? And in AIC, we saw the announcement of the Alzheimer platform trial that is actually going to use combination trials, both anti-amyloid and tau. They announced during AIC that early next year they will announce the therapy that will be using and they will start enrollment. So these combination trials are already ongoing. And I will also want to spend some time in the DIAN-TU trial platform. The DIAN-TU trial platform is implementing the first combination trial in the field and already completed enrollment in the first arm. The DIAN-TU trials is using a combination trial with open-label lecanemab and then E2814, an anti-tau agent that bind to the MTBR region of tau. This trial is already ongoing, already completed recruitment, and we'll be seeing results as we continue moving with the trial. So what I'm trying to make a point is that we are already seeing prime time not only for tau, but also for combination trials. One of the things that I'm excited about the combination trial that is being led by the DIAN-TU trials unit is that most of the results that have been coming from dominant hill mutations actually predicted the trials in sporadic Alzheimer's disease. And that's true for the solacenomab trial in this group, the gantenerumab trial, but also for the result from the crenezumab in the API-Columbia trial. And hopefully the results we see in the combination trial of DIAN-TU will also be extrapolated to sporadic Alzheimer's disease. So in a really rapid and efficient manner, we are always will be able to predict what will happen with these combination trials in sporadic disease. So again, it's a really good moment to be in the field and thinking in how we start treatment, but also how we implement this treatment in clinical practice. With that, I would like to send you a few take-home measures. I know we are post-lunch, and some of them may have coffee, but others not. So if you want to take a few notes, these are the things that I would like to highlight that, in my opinion, had a highest impact during the last year, but also we have a rapid clinical implementation, and we should be prepared for that. First, recent trends in dementia prevalence have shown that there is evidence for risk modification, and that's actually maintaining a stable or decreasing in incidence and prevalence of dementia in some countries, but it's not been similar across all populations, so different targets and approaches needs to be considered. Second, early diagnosis of Alzheimer's disease will be key, right, as some of these treatments become available and more accessible. So the use of blood-based biomarkers, both at primary but secondary levels, seems to be promising, not only for the clinical implementation, but also for rapid trial implementation in a more cost-effective way. We also learned today that there is evidence or potential evidence for prevention in Alzheimer's disease, as shown in the DIAN-TU gantenerumab trial, where the use of gantenerumab for almost 10 years seems to protect against disease onset in these mutation carriers. So that's another element that I would like to highlight. And finally, as I mentioned, it's prime time for tau therapies, and we are now seeing a lot of combination trials coming, and that hopefully will increase the effect we are seeing in terms of delaying the disease. And again, our goal is to cure the disease, but if we are able to achieve 50%, 70, 90% of lowness of the disease, that will be a significant outcome that will come hopefully from these combination trials. Right, that's all I had. I'm also Assistant Medical Director for DIAN-TU trials, and I'm happy for all what we are doing with these families and supporting them in their path to Alzheimer's disease. These are thanks for the many people that have contributed, and hopefully being able to convey what happened during AIC during the last 2 weeks, but also some of the findings in the last year. I apologize for the thousands of researchers that I know that have extremely impact research finding that I haven't been able to cover today, but again, this is some of what is going on in the field in general.
Okay, so we're going to do Q&A for Dr. Yibre.
Anyone in the room? Questions? Table? Dr. Hurtis is thinking about it. Go ahead.
Yeah, just a bit more speculative and a little out of the realm of amyloid and tau. There's clearly been an explosion of the understanding of the multiple complex underlying processes around evolution of Alzheimer's and related dementias for that matter, with translation to a lot of early stage trials targeting things other than amyloid and tau. Do you want to comment on what you see as the prospects there and the strategy that might be employed to accelerate their movement from early phase to later phase?
Yeah. So in terms of early intervention, two elements that I think are key, right? Number one, when do we intervene, right? In terms of risk factors, seems that intervening midlife, it's where we see the most benefits, right? That's in terms of lifestyle modification. In terms of early intervention, I think one key for moving in terms of these prevention trials would be how do we screen earlier, right? How do we have a population-based approach to identify people that may be at a high risk, and then we bring them early on for trials. So, and that's a little bit challenge, right? Because there is a lot of cost around that. So to me, a combination of identifying key risk factors at a population level, combined with probably screening with blood-based biomarkers in high-risk individuals would be a key element to identify that group that will benefit the most in an early intervention. The reason I'm thinking in high-risk factors, right, it's because those are also the ones that we could identify at primary care once these therapies are implemented, right? So we have a program where we identify early risk factors, we screen them with ideally blood biomarkers and see where if they are candidate for different therapies. But again, it's a lot of challenge in terms of how we identify these. Good. Excellent. Thank you.
Okay, so I'm going to present the recommendations for the research subcommittee. And if we could have the first slide up, please. The research in Alzheimer's disease has had really, I think, a phenomenal impact into what we're able to do, both at not just the clinical, the implementation level, the management and the care level, but now in the diagnostic and therapeutic areas. The investments that have been made over many years and most recently accelerated have really panned out. You saw Dr. Yibre's presentation that many in the field are extremely excited by the potential for what we're seeing in our clinical studies, our diagnostic clinical trials, and clinical trials of prevention. Some of the first prevention is being realized through these efforts. Accurate diagnosis in primary care clinics is now a possibility, and there are many things coming. That said, there's much more that needs to be done, and so now is the time to push forward and to push hard on future advances that promise to deliver these research advances into benefit health for patients. So can we go to the next slide? And I noticed that, oh, I see, thank you. And I'm going to need to look this way because I guess that one is different. Okay. Here are the committee members, and I want to thank all the committee members for the revisions this year. Really an extensive amount of work was put into these recommendations across many areas, and we had guest ad hoc contributors to this. Recommendation number one is really a recommendation based on what I was describing, which is now is the time to push forward to have these advances deliver. And so this is to increase federal research funds to meet NAPA stated aims. And I won't deliberate on each and every one of these, but there are a number of areas where increased funding is necessary in order to deliver on these promises. The ones that we wanted to highlight were understanding more of the basic biology of the disease. This is the foundation for which diagnostics and therapeutics are developed. Looking in other dementias besides Alzheimer's disease, because 1 out of 3 people who come in with dementia don't have Alzheimer's disease. They have other things that are going on, and we need to address that population with the same kind of effectiveness that we're now starting to get for Alzheimer's. Early detection of cognitive decline and precursors of dementia are quite essential. I mentioned in my earlier question that when we treat people for Alzheimer's disease, simply a year or 2 advancement changes their response to treatment. It goes down over time. And so this is where early diagnosis is going to be really essential to have the best therapeutic outcomes for patients. Recently developed amyloid treatments have an enormous number of questions now, and how do we apply this? Who do we apply it to get the best treatment? Who should not be treated with these drugs to avoid negative outcomes and side effects? Developing and implementing and evaluating the implementation of models of dementia care and support are critical. We heard about the GUIDE model earlier today, but these kind of research models that are being developed to improve care, we need to understand and compare these in a way that scientifically we understand their implementation and their effects. One important thing that has become more salient or perhaps more obvious to those of us who do research is that we can't just do research and discover things. We need to be able to deliver this into the medical system. And the medical system for treating and diagnosing Alzheimer's disease is woefully under-equipped, both in capacity, staffing, and sourcing for us to be able to do this. And so this is an area where research could tell us about the different ways to approach this. How can we do this and how we should approach it? I'll just comment on this, that it seems to at least me that this is something that you have to do while you're doing it. It's one thing to take time to do research to get answers, but we're out of time. And now in order for us to deliver this, we need to build the plane, so to speak, while we're flying it. And we need to implement this in a way and learn from how that's being implemented to deliver that. And there's multiple groups who focus on this within the governments and the agencies that can do this, but we need to engage and fund those groups in order to do the important work. I mentioned further development of diagnostics and therapeutics and the implementation process in clinical settings, not just in the research setting. Evidence-informed methods for improving prevention and risk reduction of cognitive decline and dementia. Dr. Yebre mentioned this, and some of the questions now are, what is the evidence and how do we implement this for people in midlife and beyond to further lower the incidence of Alzheimer's disease and other disorders? The long-term effects of COVID-19 were highlighted, as well as focusing and engaging on the person's lived with dementia experience and engaging that important part and stakeholder in this process. And finally, to implement a dementia portfolio that enables the translation and demonstration of scientific breakthroughs into the diagnosis, treatment, and management, and the efficient translation of evidence to patient care by the newly created ARPA-H. And so the recommendation here is to further engage with this new group to further accelerate research efforts. Recommendation number 2 is to address critical scientific and clinical questions in the implementation of the first generation of disease-modifying treatments. And I mentioned, how do we identify the people who will best respond? What about people who weren't in the trials, either due to their background or due to their comorbidity status or other things? What about subgroup analyses? Who will benefit? How much will they benefit? What is the risk-benefit ratio? These are all research questions that you can one can pursue and get answers to. Which persons with cognitive decline and evidence of amyloid deposition in the brain who didn't fit those original criteria could benefit? And there are many categories for that. Some of those, for example, are people like with Down syndrome. There are people with mutation carriers where we don't know what the long-term effects of treating asymptomatic AD are, either from the benefit or from the risk profile. And so this is something that needs to be pursued. And then I mentioned the infrastructure needed to appropriately identify, treat, and monitor people with these treatments. This is something that is being built as we speak and has started just a year or two ago. But looking into the different approaches of how do you deliver treatment, how do you implement this, what are the models that can be used will be important in further increasing our therapeutic capacity. And the last point here is the causes of side effects and adverse reactions in people who are treated with anti-amyloid drugs and how to best monitor and manage these. This is a real challenge for us in the clinic. It takes an enormous amount of time and resources for us to manage the monitoring process for ARIA, and so better ways to do this are urgently needed. Continuing on with research recommendations, in these first generation of disease-modifying treatments, early, accurate, and minimally invasive detection of the disease. We heard earlier today about a very promising approach to integrating into primary care screening models and integrating the primary care system into this identification. One question is whether anti-amyloid treatment of cognitively normal people identified as high risk for future cognitive decline based on PET or blood biomarkers can help prevent the delay in the onset. So these are the ongoing and future prevention trials. How to manage people with anti-amyloid therapy over longer periods of time who progress to dementia. And so we have open questions that were actively being discussed this year of if and when do we stop treatments, and is that treatment specific? Or is there a generalized formula? And what are the effects on patients when that happens? And finally, novel approaches for prevention and early detection of the disease, as well as the risk and benefits of disease-modifying treatments in people with Down syndrome and other forms of Alzheimer's disease. Recommendation number 3 is to implement research of active dementia care models to compare effectiveness. This is an area where I think ongoing work and ongoing implementation can be leveraged to gain information about how do these care models perform, how do they do with terms of patient care, what are the beneficial aspects of this, and can we research this similar to what we do with our drugs when we develop drugs in clinical trials. Are there ways to demonstrate benefit, and can we compare that? Again, we've highlighted the need to include persons living with dementia who are not being adequately served by the current models, and some of that was highlighted earlier today. Also, we highlight how to integrate with medical interventions and medical systems to measure the effects of quality of life, function, and their outcomes. And I'll make a comment about the current CD requirements for registry as one potential source of information to where we can gather that information. Our fourth recommendation is here to address health equity, underrepresentation of diverse populations in research, in Alzheimer's disease and related dementias. Clinical trials should be increased. This has been a recurring recommendation of the committee for a number of years, and as of this past year, we have not really had success in clinical trials. The observational studies, there are several that are doing much better. The one from this morning was really outstanding in its coverage, and I know there are multiple others that are really doing fantastic at this. But our clinical trials need to do better, and we need to get better about getting representation in these clinical trials so that we can generalize for all the people who could potentially benefit. We have some specific recommendations on ways that this might be done, including research recommendations about what are the methods, the clinical recruitment methods that are effective in success. How have the observational studies been successful? How do we translate that over into clinical trials? And I think one upshot of this is that it takes real focus, time, effort, and resources to be successful. It doesn't happen spontaneously. And so the recommendations here really, I think, are centered around how do we focus on these issues that stand in the way of this representation, and how do we determine what is the effective approach to take. Our fifth of 6 recommendations is shown here. It's to accelerate translation from scientific discovery to health impact. And this recommendation is a research recommendation because we believe that there are ways to research and understand how to accelerate that pathway from the time of discovery until the time of delivery in the clinic of these things. There are scientific ways that we can test these. There are different ways that we can develop in this translational step, and we can learn a lot, not just from our own field, but from other fields and how this was done. COVID-19 has been held up as a example, a prototype of how this can be done incredibly quickly. And some things we can replicate from that, and some things we can't. But we certainly can learn about what works and what doesn't work, and then implement those in this translational research process. Our last recommendation is here: implement scientific and evidence-based evaluations of factors for decision making. And this really is, I think, in general, just saying when we make decisions, whether it be about policy, clinical care, research and development, these kinds of things, we can apply the scientific method of evidence, information, decision making, weighing out the pros and the cons in a quantitative way, not just a qualitative way, counting the numbers, and using that information to make better, more informed decisions that will have an impact on research, and it will also have an impact on the delivery of clinical care. Okay, and I'll stop there.
Good afternoon, everyone. I'm Helen Bundy Metzger, and I am chair of the Long-Term Services and Support Subcommittee of NAPA. I'd like to introduce one of my committee members, Susan DeMorris, who also happens to be the director of the California State Department on Aging. Having been appointed by our governor, Gavin Newsom, approximately 3 years ago to this role, prior to this, Susan actually led the California chapters of the Alzheimer's Association, Public Policy and Advocacy. So she has extensive knowledge in this field, absolutely representing the needs and wishes of those who are caregivers in this role and individuals actively living with dementia. So it is my honor to welcome her today.
Thank you very much, Helen. I appreciate the introduction and the honor of sharing some slides today before you hear the LTSS subcommittee report recommendations from the LTS subcommittee. as we move forward, thank you, Helen, for advancing the slides. Let's see. Wonderful. The background for the slides that you're about to see, and I'm going to move through them very quickly as a whirlwind. LTSS is really a multiplier. We wanted to be sure when you see the depth and breadth of our committee recommendations that they lift individuals with dementia, people living with Alzheimer's disease, as well as family caregivers. And so that's why we have quite a few recommendations, because LTSS benefits a very large community. And as we've seen in recent years, with significant, substantial investments in LTSS through the American Rescue Act, the CARES Act, and others, that these investments in LTSS have really made significant improvements in the quality of life for individuals, families, communities, and our society. So we wanted to frame the issue a bit before we go into our recommendations. And we had a couple of gripping presentations at our subcommittee. We heard about people living on the margins. We learned about individuals who are incarcerated and the high number of older adults who are incarcerated nationwide, who are now living with Alzheimer's, dementia, and other cognitive impairments. We also heard about the increase in older adult homelessness nationwide, and how many people are living with cognitive impairments who are now unhoused. And that really led to this presentation where we heard about people who are homeless for the first time. And for many of them, they've been providing care to a parent or a family member. And when that older adult is placed or passes away, they lose their housing and they're homeless for the first time. So really a focus on people who are living on the margins really was gripping. And then in my personal life, I have a dear friend in Sacramento, California, a small business owner. Her business suffered through the pandemic and she's been able to build it back up. Her mom is living in Sun City, Arizona, has been diagnosed with Alzheimer's disease, and the family made a decision to move the mom to Minnesota so she can receive excellent Alzheimer's care. And so my friend is giving up her business, relocating. She and her mom both are leaving their social networks in Sacramento, California, and Arizona to establish an entirely new life in Minnesota. And it really just hit home the supreme sacrifices that people make as family caregivers. So we'll move to the next slide, please. I sourced lots of this material in this slide deck from a number of experts, and they're listed here, and there are others as well. So thank you to all of the contributors with the reports that you have shared with the public. Next slide. We know today more than 11 million Americans would qualify as dementia caregivers. Not all may identify as dementia caregivers. And we know they provide, from the Alzheimer's Association's most recent facts and figures, over 18 billion hours of unpaid care. And the total economic value to our nation of this uncompensated care is $350 billion. Roughly the equivalent of the entire American Rescue Plan Act. So when we look at LTSS, we've got the ARPA dollars, and then we've got the uncompensated care dollars in roughly equal dollar amounts. Next slide, please. We know that dementia caregivers, the majority are women. Their average age is 49, just about 50. And increasingly, we see a large number of caregivers who are between the ages of 18 and 34. And lots of research that supports that the role of caregivers varies greatly by race, ethnicity, language, culture, LGBTQ status, and income, with very disparate experiences and burdens across the country. Next slide. We hear often in our work with family caregivers in California and nationwide the very positive benefits of caregiving, how rewarding the experience can be, how meaningful and purposeful, and what a gift and blessing and privilege it is to give back to family members and friends. And we don't want to lose sight of the very positive benefits of family caregiving. Next slide. We also know from research, data, and firsthand experience about the disruptions of dementia caregiving and how it impacts individuals in their own lives, the caregivers in these areas. The health impacts, the mental health impacts, financial pressures, preparedness, helping people obtain a diagnosis, and a care plan, work interruptions, elder justice, and housing stability. Next slide. With this very distinguished federal table, we know from the CDC's behavioral risk factor surveillance survey now, kudos to the CDC for including caregiver burden, and so many states that now survey their populations around caregiver burden. We know among all caregivers, almost half, over 40%, report having 2 or more chronic diseases themselves. And a large number, 38% of dementia caregivers report physical stress. Next slide. With respect to mental health status, we know that just about 60% of dementia caregivers report high to very high stress. A significant number were socially isolated with no other family or friends to assist them with caregiving. This is my concern for my friend who is relocating to Minnesota without a network of support, and that many caregivers describe having no choice in their role. Next slide. I wanted to highlight, we've been so fortunate in California to be beneficiaries of ARPA dollars for a number of LTSS demonstrations, pilots, and one-time funding. And we're incredibly grateful to our federal partners for these resources. One of those pilots was an Alzheimer's daycare resource center model that we were able to fund statewide. And this is one of our extensive interviews with the caregiver participants. And they're just heartbreaking to hear from the caregivers about how beneficial the day programs have been in their lives. And to hear that somebody was contemplating suicide before discovering this Alzheimer's Day program that was made available only because of ARPA dollars. Next slide. We hear often about the financial pressures of dementia caregiving. We know that dementia caregivers spend double other caregivers out of pocket, about $12,388 annually, as compared to $6,667 for other conditions. Next slide. Again, sharing from one of our participants in our ARPA-funded work, looking at, this is a family that has long-term care insurance, which is increasingly rare. And even in this case, the family is looking at $15,000 a month out of pocket for round-the-clock home care. And that doesn't even include assisted living or skilled nursing costs if they were to contemplate those placement options. Next slide, please. Given the average age of dementia caregivers, we know that 6 in 10 are in the workforce full or part-time. And for those who leave the workforce, it's not simply leaving their job, it's sacrificing health insurance benefits, accrual of sick and vacation leave, full-time work, career advancement, retirement contributions, Social Security credits, and paying into unemployment insurance. Next slide. From one of our program participants, we heard quite a bit from family members family dementia caregivers who are able to continue working or to resume working or to work part-time because of the Alzheimer's daycare program. And in this case, somebody was on the brink of taking a leave of absence for work that they were able to avoid. Next slide. Again, one of our partners, Caring Across Generation, that does a lot of work nationally, shared this story from a woman caring for her mom with Alzheimer's disease and facing her own retirement now as she turns age 50 and having cashed out her own 401k and suspended her own retirement savings and career in order to be a caregiver. Next slide. We hear about the training challenges. Many caregivers are unwilling to bring people into their home because they don't have confidence in the skills and abilities of home care agencies. As well, many dementia caregivers have expressed to us a lack of confidence and skill in their own abilities, that they've not been trained, they don't have the knowledge, especially with some of the really intimate caregiving tasks and hospital discharge that they really feel ill-equipped to handle. So we've been able to train about 90,000 direct care workers and family caregivers with over 600 courses in California with our ARPA funding. And this is a quote from one of our trainees who has shared the multiplier effect, how this training helps them with their paid and unpaid caregiving, but they also have been able to share it with their network of family and friends, many who are doing the same. Next slide, please. In our elder justice work, we know, and earlier we showed the statistic that many dementia caregivers feel they don't have a choice, and many did not seek out dementia caregiving, and that causes a lot of tension in the home. There are financial pressures. Sometimes the living situations are not ideal, and that contributes in many cases to elder abuse and neglect when people are really at their limit. And we know that people living with dementia are at higher risk of all forms of abuse. And that's part of our elder justice work in California and nationwide. Next slide. In the presentation, we heard as a subcommittee about older adult homelessness and seeing the trend nationwide where 50 plus is really the fastest growing unhoused demographic in our country. And we've been fortunate to do some work with HUD in California in a housing accelerator that involves our Medicaid program and our State Department on Aging to look at this unique demographic. Next slide. We have an excellent study that we heard from the statewide study of people experiencing homelessness out of UCSF. And it's alarming that 41% of this group became homeless for the first time at age 50, and that the warning time was as short as 5 days. And what this points to is a significant life event for this population, a health crisis, a change in living situation because they've been a caregiver or they've been living with a parent or family member, eviction notices. Next slide, please. And then I just wanted to close. I tried to touch on some of them, but there are so many more than you see here on the slide. I heard earlier, I forgot to mention the incredible work being done by CMS in the behavioral health space. Of course, the GUIDE model, the approvals of Medicaid waiver programs that fund respite, home modifications, and housing supports that expand the definition of LTSS. And of course, the great work happening with the Raise Family Caregiver Act, the National Strategy on Family Caregiving. And I wanted to especially give a shout out to the Administration for Community Living in their final rule for the Older Americans Act they have specifically and explicitly named family caregivers as a new target population for state units on aging across the country. They've always been a priority population, but they're named explicitly throughout the Older Americans Act, and we want to give thanks to ACL for that. And I will conclude now and turn it back to Helen. Thank you.
Oh my goodness. Yay, Susan. Yeah. Helen, do we want a Q&A or leave it alone? Yeah. Yeah. Now, I wanted to double check and see, even though we're going to go into the long-term services and support subcommittee recommendations, Susan has highlighted a lot here, and we will take it steps further over the next few minutes. But if anyone has any questions here in the room or online, those that are in our virtual space, please let me know. Either that or we will proceed. Well, Susan obviously covered it quite well. So I'm going to give her just time to rest and relax. And now should we get to go to our recommendations? Obviously, you know I'm Helen, but I want to thank Susan for really highlighting the unpaid caregiver. She really, many of us on this council have been directly, related to someone. It has been in our sphere, the needs of obviously the person living with dementia, but it tends to be the person in the background that is often somewhat ignored. They can be ignored in the clinical setting, they can be ignored in the community setting, but we are intimately aware as members of the Napa Council that their sacrifice is made. And we want to acknowledge those. We want to also acknowledge their contributions to the quality of life of the individual living with dementia. Our healthcare systems, they are the backup. They are the backbone that is there to execute your recommendations and to carry out your summaries. And to our country, you saw the numbers. The value of caregiving hours is absolutely more than significant. It's monumental. And without the caregivers in the background pushing forth every day, as we've heard from the World Health Organization in the past, it could bankrupt nations' economies. So we're going to move forward with the slides, and I'll see if we can get it going. Come on, there we go. So first I'd like to acknowledge all the members of my subcommittee, both the non-federal and the federal. Thank you for all your work this year. So we'll move on. So we have 11 recommendations, so I'm not going to bore you with every detail because they're so in-depth. LTSS is incredibly broad and in-depth in its scope. So I'm going to kind of go through as relatively quickly as I can. But has been previously stated, right? The reauthorization and budget appropriations for NAPA. We're asking that NAPA be reauthorized for another 10 years and that funding be included for personnel to coordinate and support us, to support our work, including tracking the progress from year to year so that we can really spend our time prioritizing, and then they can assist us to optimally convey recommendations. So, recommendation 2, amend the Older Americans age eligibility requirements and increase funding to expand delivery of services in the OAA for people of all ages living with AD-ADRD and their family caregivers. Now, currently, individuals 60 plus are eligible for services authorized under the Older Americans Act. However, we are asking that this be changed to include all people living with ADRD and their caregivers. And so highlights of our requests are: Congress should increase appropriation to increase capacity to reduce existing wait lists, which are extensive throughout the country, and expand delivery of services. At the same time, a system of tracking and evaluation should be developed. This service delivery should include expansion of education, training, and respite care through the National Family Caregiver Support Program. In addition, the funding of the NFCSP to the states should be increased to reduce at their level waiting lists and expand service delivery. And we ask for a significant increase in funding to further the state's compliance with the civil rights laws applicable to persons with disabilities to be respective of those with ADRD. All right, recommendation number 3 is to expand the availability of dementia-capable home and community-based services available to people living with dementia and their unpaid caregivers. Now, we ask the Government Accountability Office to evaluate, the impact of the American Rescue Act. And that way, they can look at other investments also to then further build and sustain dementia-capable initiatives. We also recommend that the following be approved for or researched and also improve respite options. At the state level, make home and community-based day and overnight respite services available through LTSS programming. Then we should look at respite care options, the government under HRSA, and how they are impacted by the direct care workforce crisis, how recruitment, sustenance, and the educational challenges there, and then make recommendations and how these issues need to be identified. CMS should expand the outpatient caregiver training benefit to include respite care for all caregivers, comparable to that of the GUIDE model. And states should absolutely explore Medicaid waiver options to fund respite support. We also ask Congress to double its funding to the Lifespan Respite Care and Lifespan Respite Care Enhanced grants to provide more respite for all family caregivers. So we'll move on. Recommendation number 4, define needs and expand LTSS to people living with young onset ADRD and their families and caregivers. We ask Congress, please, to do the following: authorize funding to gather data on the number of people living with young onset dementia. Currently, we only have estimates, both in the insurance sector and in the public sector. We need to define how many of us are out there. I will also reiterate that we want to see Congress approve legislation to exempt eligible people living with young onset from the current 24-month waiting period to receive Medicare benefits, as has been done with those with ALS. We'd like them to appropriate funding to provide grants to LTSS providers to develop tools and programs to assist this population to address not only their short-term, but their long-term housing, legal, and financial concerns. We also wish to have them appropriate funding for grants to provide comprehensive support and resources for caregivers of those with Down syndrome, as they have an increased risk or may already have Alzheimer's disease. Further, we'd like to see SAMHSA, they should conduct a study to determine the suicide rate of people diagnosed with dementia by age and highlight those with young onset, as we know that they have a higher rate than those diagnosed at later ages, and should do it for the first period of 1 year post-diagnosis. Then we move on. We're going to address the It's a continuation of recommendation 4. We need to address the barriers to LTSS for people with intellectual and developmental disabilities. We recommend interventions at the state level to reduce Medicaid wait lists for home and community-based services, to devise a system of comprehensive home-based and home and community-based services, to develop programs that actively reach out to this population, and to develop a system to prioritize service delivery for those on wait lists. For the LTSS workforce to meet the needs of the IDD population, in addition to the topics that I will later discuss in Recommendation 7, we ask for these additional items. Competency training in IDD and AD-ADRD needs to be developed and available to all LTSS providers and direct care workers. And I want to applaud the CDC convening with the NTG for their collaboration in this area. States also need to use the nationwide system for background checks for all agencies and individuals providing services. Then we ask CMS. They should encourage all states to revise their existing Medicaid policies to allow redirection of funding from mandatory institutional care to person-centered home and community-based services. Then, NIH and ACL should continue to support the development and scaling of evidence-based interventions for those with IDD at risk of or living with AD-ADRD, including tailored dementia education and training for LTSS providers, strengths-based person-centered support for caregivers, tailored education programs, support groups, and information specific to the intersection of IDD and Alzheimer's disease. Promote tailored home and community-based services, now including, but not limited to, respite care, day programs, and shared living models. Recommendation number 5. Expand the availability of culturally and linguistically tailored LTSS to high-risk populations, inclusive of those with the most social and economic need, including, but again not limited to, rural and tribal populations, those with limited English proficiency, and LGBTQ+ populations. Now, knowing that community health workers are trusted community members and they serve as a link between health and social services and the communities they serve, the NAPA Committee recommends collaboration amongst home and community-based community health workers employed by various healthcare networks and community-based organizations to provide holistic and system-integrated services. A study should be conducted on the impact and return on investment that community health workers can have on underserved communities. That should be undertaken as soon as possible. Congress should appropriate new or increase existing funding to provide state grants to expand the network of community health workers working with the aging population. We need to provide incentives for diverse businesses and nonprofits to become dementia-capable providers. We need to expand the aging and disability resource centers. There are only a handful throughout the country. Along with the no wrong door systems, we need to have them in every state. To private and nonprofit organizations for the development and implementation of innovative, multilingual technology solutions. Grants in this area would incentivize them to get moving on it so that all of our populations, no matter what nation you may come from, the community you belong to, or the language you speak, would exclude you. They need to be included. Recommendation number 6. Identify adults with AD-ADRD living alone. Then develop and implement strategies to address their LTSS needs. We know that more people in this country, for whatever reason, whether by choice or whether by circumstance, are living alone as they age. So we recommend that ACL should encourage the participation in all aspects of the national survey. And that is the national survey being undertaken by ASPE with the technical company Mathematica, called Identify Adults with LTSS Needs, and include a question: what is the number in your household? Then we can help define those that are living alone. Create an interagency work group to build capacity to support people who are living alone with cognitive impairment. And then we should, in fact, ACL continue to promote and fund expansion of dementia-friendly communities to help address social isolation. All right. Okay. So we're still on 6 here, and this covers additional items. Let me see here. Okay, let's get on to CMS. So CMS should, in fact, increase the number of hours permitted for in-home caregivers. Encourage more states to expand Medicaid eligibility for those living alone with cognitive impairment or dementia. Encourage, as I spoke to earlier, Medicare Advantage plans to add services that specifically support those living alone. And then we're asking that can CMS substitute the GUIDE model respite benefit to allow GUIDE-enrolled people living alone without caregivers to hire in-home care services as an equivalent benefit. Congress should pass legislation authorizing tax credits, including refundable tax credits for those with no filing requirements living alone, so that it can help defray the cost of hiring direct support workers. Allow Social Security to allow family caregivers to earn credits as part of their caregiving time as part of their employment history. I personally lived through that, giving up jobs and early retiring to care for family members. But for some people, it means the difference between them getting Social Security benefits or not. So, recommendation number 7. Implement solutions to address the LTSS workforce crisis. As we continue to experience an LTSS workforce crisis, we therefore are going to carry forward many of the recommendations from the 2023 report. But initially and additionally, I'd like to ask for a congressional funding increase of $25 million for expansion of HRSA's geriatric workforce enhancement program, and request that the CDC allocate a portion of BHI and BOLD funding towards public health workforce training in AD/ADRD. Now I'll list just the headings of prior year's recommendations. Item B, increase of efforts and implement system solutions at the federal level to address the workforce crisis. Next, item C, establish a national caregiver pathway for career advancements. D, provide incentives for people to enter the workforce, of which there are many, and I won't beleaguer them, but you can check back and review the slides. E, increase availability and improve training and supervisory support for people providing direct care for people living with dementia. And we'll move on to recommendation 8. Expand awareness and engagement in the public and private sectors about AD/ADRD. The federal government should encourage all states to secure an executive order or enact legislation to create their own multi-sector plan for aging so that they can align their state and local priorities, break down the silos, and encourage public-private partnerships. We'd also like the government to strengthen its collaboration with the Ad Council. Let me see what we're doing there. Did it go too far? Let me take you back, please. We'd like the government to strengthen its collaboration with the Ad Council to expand communication around AD/ADRD through public service campaigns beyond the internet. Those people in the outer areas may not have broadband. They may not have smartphones. Those in our various language communities, they need print media, they need radio communication, they need television communication. Not all of us are internet savvy. So we also need to have the government develop crisis care response standards that are inclusive of dementia. And we'd like to encourage every state to develop and implement their 988 crisis programs and include dementia awareness training for all first responders. Recommendation 9, increase funding to implement strategies to reduce risk of homelessness among older adults living with dementia or cognitive impairment and to respond to the needs of those already experiencing it. You heard earlier from Susan, and we heard last quarter from Dr. Kushel, the numbers of the 50-plus population in homelessness is greatly expanding. So Congress should increase funding as follows: to the states to expand adult protective services to enhance services for those at risk of homelessness, for residential care for low-income people most at risk for homelessness, and then funding to develop permanent supportive housing for older adults facing homelessness so we can support them, keep them safe, and not have them end up on our streets. Recommendation 10, implement strategies that create conditions for high-quality, person-centered, and strengths-based long-term services and supports throughout the course of the disease. Health and Human Services should continue to develop and enhance distribution of public information on the importance of advanced care planning, options for financial and health care decision-making, long-term care settings, and more. Define the role that healthcare and LTSS providers could play in the distribution and support of these options so that planning is done early in the dementia journey. They need to develop a strategy for broadening public awareness of palliative care benefits. And I'll move on to our final recommendation. And this is going to cover develop and implement systems and programs that support people living with dementia while incarcerated to provide appropriate treatment from the point of diagnosis through to end of life. We recommend the convening of a task force to develop criteria for compassionate release, otherwise known in some states as medical release, for people living with dementia while incarcerated, to provide guidance to all states, including establishing a system of regular dementia screenings, develop an advocacy program to not only assist people living with dementia to start the process of compassionate release, but if necessary, to provide a legal advocate for representation throughout hearings before the parole boards. Because at the current time, an individual who is seeking compassionate release has to go through this process on their own. We actually ask for encouraging prison systems to offer advocates or case managers to assist benefit applications prior to release and to develop post-release plans. We ask that they develop and implement mandatory dementia training for all prison personnel and members of parole boards. And for those ineligible for compassionate release, programs should be developed and implemented within prison systems, inclusive of peer-to-peer support models and safe spaces. Create those so that they can have a respectful end of life, possibly in care or possibly even memory care. So that I put these forth respectfully, and I want to thank you for your patience through all of 11 of these and your attention as we tried to put forth as much as we could within the broad spectrum of LTSS throughout our country. Thank you.
Thank you, Helen. Thank you, Susan. Thank you all. This is a lot to digest, so we're going to take a 15-minute break, and we will come back at 2:45 and do risk reduction, vote on recommendations, and do public comments. So back soon. Thanks.
Produced by the U.S. Department of Health and Human Services.